About 4 years into practice, I got up and, shocking to most of you, I started yelling at a meeting that we should not be using implants. We should be using K-wires. They're effective. There's no reason to use all these expensive implants. And I had a few complications and went through the literature. Buddies of mine published some stuff, and really K-wires are not as simple and as effective as we thought. And there's some good data to show that maybe we can do better. And I'll try to prove that to you here because that's been my experience. So we look at the background. We know it's a fixed deformity of the PIP joint. That's what we're talking about. It can be isolated or with the claw toe. I'm not here to go over semantics about a claw toe versus hammer toe, but some sort of curved deformity of the PIP that's fixed as a rigid hammer toe, and that's what we're talking about. We all really don't like talking about the subject because dissatisfaction rate is quite high. No matter what you do, you make it perfectly straight. They don't like that. Leave a little curve. They don't like that. It's a little flexible, and it goes coronally somewhere. But we have to deal with these patients. It is what we do. And the goal that I think for all of us to get the toe straight and keep it straight. It doesn't count if it's straight at post-op week 3, post-op week 4, and then at 3 months out it's sideways. They don't really appreciate that. The anatomy we all know is a imbalance of the long extensors versus the intrinsics, multiple etiologies. But let's talk about the K-wires. So many people say, my K-wires work just fine. Why need an implant? And I was that person. Well, the truth is when you look at it, there's a high recurrence rate. Nobody wants a crooked toe after surgery, even though I convince them that that's just quote-unquote part of the deal. It's really not an acceptable way to treat a patient. So at 3 weeks, if you pull the pin, the recurrence rate was 47.8%. So that's not an ideal thing. So if you're going to use K-wires, you got to leave them in longer. But even if left at 6 weeks, there was about an 8.7% rate of recurrence. So you pull the pin out, and that toe's going sideways about 10% of the time. Well, I'm just going to leave my K-wires in longer, but, nobody wants an infection after surgery. If you ever had to deal with an osteomyelitis of the PIP, has anybody actually dealt with that? True osteo of the lesser toes? Yeah, that's a lawsuit. It happened when I was in fellowship. It happened to me in practice, and it's a disaster. It's really hard to deal with. You can do all sorts of fancy clean out the toe. Typically, in the end, it's Dr. Doty's favorite surgery for that problem, and that's usually what you end up with. And that is not what the patient came in with for a crooked toe. So osteo of the toe, it can occur. As we all know, if somebody calls in post-op with redness and swelling of the toe with the K-wire in it, don't put them antibiotics, rip the pin out. You'd rather have recurrence than infection. That's usually the mistake. But when these guys looked at their data, they had a 5% rate of infection when they did an open correction, which is an open PIP arthroplasty/fusion. But even when they did it percutaneous, they had a 2.2% rate of infection of the lesser toes. That is not an infection rate that's acceptable. We've gone through our infection rate for all of our procedures. It's about 0.3%. That's everything that we do. So 5% infection is unacceptable. I think if you told the patient pre-op, 5% of the time you're going to get an infection, they walk out of your office because I don't think that's an acceptable infection rate for surgery. And the issue is, and this is, these are really good surgeons. If you know these guys, Beat Hinterman and Marcus Knupp, they're probably some of the finest surgeons in the world. They looked at their data for subclinical infection, and what they realized was that there's a recurrence associated with subclinical infection, not that pus shooting out of my toe. And they looked at the recurrence rate, 6-week K-wires, 39% with a stainless steel K-wire, and it was lower with a titanium K-wire. And when they looked at this more scientifically, what they saw that the K-wires are never clean. Steel K-wires are more contaminated than titanium K-wires. So if you're going to use a K-wire, use a titanium K-wire. But even then, those are heavily contaminated by 6 weeks. And the bacterial load is real and multiple organisms, and that's probably why these patients get a lot of recurrence and their toes are really swollen. I think we all experience that. Like, oh, my toe's kind of fat at 2 months. You're like, oh, that's okay. That's what they all look like. It's probably not true. It's probably because they had a subclinical infection. The body's just fighting it. And so it's subclinical infection, true infection, high recurrence rate, instability, that K-wires really are not that great in the long term for our patients. We can do better. That's where all these implants come into play. The Dynamite is the newest implant that's available, and it takes advantage of the nitinol and the dynamic compression. It's the first threaded nitinol Hammertoe implant on the market. It's cannulated, so it's really easy to use, and it can use it at room temperature, so none of that difficulty with keeping it cold and all that stuff that you see. I really have no idea which one is better for a patient. I've had patients complain that their toe is too crooked and their toe is too straight. So I don't know what you tell them anymore. It is easy to implant, which is key. A lot of these devices are very difficult to pop into the middle phalanx, and so this makes it really easy. It screws right into the middle phalanx, which is critical. When you put it in, it just screws right into the middle phalanx, and you can pop it into and I'll show you that, pop it into the proximal phalanx, and the barbs will deploy, and you can actually expand them a little bit more with the K-wire to really get that proximal purchase. There's multiple size options, 12, 14, and 16, whatever you so choose. The good thing is you're not taking out a lot of bone. You're not going to compromise a lot of bone. God forbid you got to revise these things. You don't have a huge screw up the pike sometimes, which can be annoying. But there's, the key for, I think, when you look at Orthopedics' portfolio is that they have multiple options. This is a really nice, easy option. That's what it looks like. I'll show you a case in a second. The retrofusion screw is another very good option. It has cancellous threads aligned in opposite directions, so you can actually generate compression. And if you haven't done this in the lab, I suggest you do. It's really easy to use. You pre-drill the proximal phalanx just like you would for if you're using a standard K-wire. And then you go out the tip of the toe with the screwdriver / wire out the tip. And then what you do is you drive the device into the proximal phalanx. And then you back it up just a little bit. And then you will engage the toe into the distal aspect of the thread. And then you back it up into the middle phalanx counterclockwise. And then you just go clockwise. And I'll show you here. Partially backs out into that middle phalanx, and as you go back clockwise, because of the unique thread design, it'll compress, and it actually does beautifully work. It'll compress it. There's much longer lengths available, so you can get it all the way up to that base of that proximal phalanx if you choose. It's my preference. If you're going to use a screw, I try to get as close to that proximal phalanx as possible, the base, to get as much purchase as I can. And this is a case example of the Dynamite. This is not my case, courtesy of Dr. Joseph Park. We don't have this available at my institution yet for the Dynamite. It just came out. So it had a bunionectomy, but it has that hammertoe deformity and a crossover toe. So we're not going to talk about the crossover. Dr. Doty's talked about that already. It's a small 1.1 millimeter nitinol wire. It goes up into the proximal phalanx in retrograde fashion. You then drill with the cannulated drill to the laser line. So it's very user-friendly. Once you have that done, you go in the intermediate and distal phalanx with the K-wire, and then you keep the K-wire obviously out the tip of the toe, and there's the nitinol implant. It's very straightforward. You then screw it into the toe. We'll show you right here. It just screws right in. If you're going to use a 7-degree angle, you have to make sure that you have the device properly rotated, because you don't want to go one way or the other. So if you're going to use a straight, it's almost a no-brainer. You want a perpendicular to the proximal phalanx, so the tines go in the coronal plane, medial lateral is what you're looking for. And you take the K-rod out the tip of the toe. Standard fashion for these implants is to grab the proximal aspect and you push it in to the proximal phalanx, compress it, and then the tips will deploy and you've got your compression. One of the nice things is that sometimes, depending on the anatomy, with nitinol, it'll expand on its own, obviously, but it may not give you that all of the expansion because there may be a little bit of bone or cancellous bone in the way. So what happens with the way Orthopedics designed it, the K-wire then gets pushed up proximally, and it'll force deploy and get more expansion and really drive those tines into the bone so that you get capture. And obviously the nitinol is going to continue to expand and keep it where it wants to go. It's a very user-friendly system. Then you pull the wire out and you're good to go. If this works, then that's what you do. In this case, you went across to hold that MTP joint, but if you don't have to do that, that's what it looks like. It's very easy and simple to do. This is courtesy of Dr. Vora for the retrofusion screw, but you see here, it's got a hammertoe with the bunion. I'm going to ignore the bunion because he's going to talk about some cases, but you can see the retrofusion screw. It has excellent length. You get up in that towards that proximal phalanx, you can get easy compression of the toe, keep it nice and straight. So lots of options. They also have the PIP darts. They have trim it pins you can use for revisions and DIP fusions. My favorite is to use the micro headless screws when you've got to go back in or they get a mallet toe. I go back in and just use a micro headless screw all the way up the pike. They have the longer ones now because of the MIS, so you can really get a nice fixation of it. And one tip that I do for my patients, I don't know what the other people do, but when I do a PIP fusion, I'll cut the flexor from the dorsal aspect to minimize the risk of a mallet toe, because I've seen a bunch of mallet toes after these PIP fusions, and those patients are typically pretty upset. And so I'll just cut the flexor at the same time so they minimize that contracture, that DIP joint. And so I'm not a religious man, but I respect great people. And so this is Pope John Paul II, which I think all of us can say was a great man. Do not be afraid. Do not be satisfied with mediocrity. Put out into the deep and let down your nets for a catch. Now, he's not obviously referring to hammer toes, but You know, we should not walk around and say my K-wires do fine. K-wires are just mediocre surgery. I think everyone in this audience is not here to do mediocre. We can do better. We should do better. And if you look at the data that's out there, that complication from K-wires is unacceptable in the modern age. Thank you.